You go to your annual physical. Your doctor orders a blood panel. The results come back and your doctor says everything looks normal. You go home. You continue to gain weight, feel exhausted, and wonder what's wrong with you. Here's something you may not know. The standard blood panel ordered at most American annual physicals is designed to screen for common serious conditions. It is not designed to identify the subtler metabolic imbalances that make weight loss difficult or impossible after 50. And many of those imbalances are both real and addressable, if someone actually looks for them. Today I'm going to tell you about 3 tests, or rather 3 testing areas, that I think should be part of the evaluation of anyone over 50 who is struggling with weight, but that most primary care physicians do not routinely order. I'm also going to tell you exactly how to ask for them at your next appointment. Hi, I'm Dr. James Miller, family physician. This is the insider information your doctor may not have time to give you in a 15-minute appointment. Before I get into the tests, let me explain something about the healthcare system that's relevant here. A standard American annual physical gives a physician 15 to 20 minutes with a patient they may see once a year. In that time, the doctor is screening for the most common and immediately actionable conditions: diabetes, heart disease risk, cancer screens, cholesterol, blood pressure. The goal is to catch things that will cause serious harm if missed. This is not a complete metabolic workup. It is a triage. And many of the tests I'm about to describe fall outside what time constraints and insurance reimbursement structures make routine. This is not a criticism of your doctor. It's a description of a system. And knowing this, you can be your own advocate. First testing area: a complete picture of insulin and blood sugar, not just fasting glucose. The standard panel includes fasting glucose. That's one data point. It tells you what your blood sugar is at the single moment you walked into the lab after not eating overnight. It does not tell you how your body handles blood sugar under normal conditions. It does not tell you how much insulin your body is having to produce to manage that blood sugar. And it does not tell you where you've been trending over the past 3 months. Here are the additional tests I recommend requesting and what they tell you. Fasting insulin. This is one of the most revealing and consistently under-ordered tests in metabolic medicine. Your fasting insulin level tells you how hard your pancreas is working to keep your blood sugar in range. If your fasting glucose is normal but your fasting insulin is high, your body is compensating. Your cells are becoming resistant to insulin, and the pancreas is ramping up production to maintain control. This is early insulin resistance, and it is strongly associated with abdominal fat accumulation, fatigue, carbohydrate cravings, and inability to lose weight. The frustrating thing about early insulin resistance is that fasting glucose often stays completely normal for years, while fasting insulin climbs. By the time fasting glucose becomes abnormal, you're well into the problem. Fasting insulin catches it earlier. The other test in this category is hemoglobin A1C, which measures your average blood sugar over the past 2 to 3 months. This is now routinely ordered, so you may already have it. But if you don't, ask for it. It's a much better picture of your ongoing blood sugar management than a single fasting glucose. How to ask for these? I'd like fasting insulin ordered alongside my fasting glucose. And if A1C isn't already on my panel, I'd like that too. Most physicians will order these without resistance. Some insurance plans cover fasting insulin, some don't. It's worth calling to check, and if it's not covered, out-of-pocket cost through a lab is often in the range of $30 to $50. Second testing area: a complete thyroid evaluation, not just TSH. TSH, which stands for the hormone your brain uses to tell your thyroid to work harder or slow down, is the standard thyroid screen. And for diagnosing overt hypothyroidism, it's useful. But there is a significant population of people, particularly women over 50, who have normal TSH and subtly dysfunctional thyroid hormone metabolism. Here's the issue. TSH tells you whether your brain thinks your thyroid is working adequately. It doesn't tell you what's actually happening at the cellular level. There are 2 additional pieces you need. Free T4 is the main hormone your thyroid produces and releases. It's the raw material. Free T3 is the active form, the hormone that actually enters your cells and determines how fast your metabolism runs, how warm you are, how much energy you have, how your gut moves, how your hair and skin look. Your body converts T4 into T3, and this conversion can be impaired even when T4 levels look normal. There are people walking around with normal TSH and normal T4, and low normal or frankly low free T3, whose cells are not getting adequate thyroid signal, and they are tired, cold, constipated, losing hair, gaining weight, and being told their thyroid is fine. The additional test I often add is thyroid antibodies, specifically TPO antibodies. Elevated thyroid antibodies indicate Hashimoto's thyroiditis, an autoimmune condition that is the most common cause of hypothyroidism. Hashimoto's can exist for years with relatively normal hormone levels, but progressively damaging the thyroid. Identifying it early matters for treatment approach, including dietary interventions like reducing gluten in people with Hashimoto's where there is an autoimmune connection. How to ask for these. In addition to TSH, I'd like free T3 and free T4 checked. And could you also add TPO antibodies to screen for autoimmune thyroid disease? Some physicians will push back on this as unnecessary. If they do, you can say you've been symptomatic, fatigued, cold intolerance, weight changes, and you want a complete picture. You have every right to ask. Third testing area, vitamin D and stored iron, specifically ferritin. These are not exotic specialty tests. They are readily available and frequently reveal deficiencies that have direct, significant impacts on metabolism, energy, and weight. Vitamin D. The standard blood test measures 25-hydroxyvitamin D, often just called vitamin D or 25-OHD on your lab report. The normal range on most lab reports goes down to 20 nanograms per milliliter, but the research on optimal metabolic, immune, and cardiovascular function suggests the target should be somewhere between 40 and 60. Many Americans, particularly those living in northern states, those who work indoors, and those with darker skin, are well below even the minimal normal range. Vitamin D deficiency is associated with insulin resistance, obesity, increased cardiovascular risk, and impaired immune function. There is also evidence linking low vitamin D to reduced testosterone in men, which affects both metabolism and muscle mass. I am consistently surprised in my practice by how many patients have never had vitamin D checked. Ask for it if it hasn't been on a recent panel. If it's below 30, supplementation is indicated and we can discuss dosage. If it's below 20, it's significantly deficient. Ferritin. This is the storage form of iron. It's different from hemoglobin or serum iron, which are the standard iron-related values on a blood panel. You can have a completely normal hemoglobin, meaning you're not clinically anemic, and have a ferritin that is low. Low ferritin means your body's iron reserves are depleted. Why does this matter for weight loss? Iron is essential for energy production and oxygen delivery to muscles. Low ferritin causes fatigue that is real and significant, not just, I need more coffee, tired, but the kind of profound fatigue where exercise feels genuinely physically harder than it should, where motivation to move is impaired, where recovery from activity is poor. I've had patients who couldn't understand why they felt exhausted at light activity. Ferritin of 11, technically not anemic, functionally depleted. Treating the ferritin through dietary changes, iron-rich foods, sometimes supplementation, changed their energy picture dramatically and made everything else possible. The optimal ferritin range is debated, but for women I like to see it above 50 nanograms per milliliter for good functional energy. Many labs report normal down to 12, and a patient with a ferritin of 15 will be told normal while being genuinely functionally impaired. How to ask for these. Can you check my vitamin D level, the 25-OHD test, and also my ferritin? I want to make sure I'm not deficient in either. Let me give you a simple script for your next doctor's appointment. I want to work on my metabolic health and I've been struggling with weight. In addition to the standard panel, could you add fasting insulin, free T3, free T4, thyroid antibodies, vitamin D level, and ferritin? I've been reading about how these can affect metabolism and I want a complete picture. Most physicians will respect a patient who comes in prepared and informed. You may get a physician who says some of these aren't necessary or aren't covered. Be persistent. These are all legitimate clinical tests for someone with metabolic complaints. They are not alternative medicine. They are standard labs being applied more comprehensively. I want to be direct about why this matters. The American healthcare system is very good at treating acute illness. It is structurally less good at the kind of thorough, investigative, proactive work that identifies why a person's metabolism isn't functioning optimally. That's not because your doctor doesn't care. It's because 15 minutes once a year is not enough time to have this conversation. and the incentive structures in medicine reward treating disease more than preventing it. You have to advocate for yourself. These tests are the starting point for understanding what's actually happening in your body. Not what a scale says, but why it says it. Next video, I'm going to settle a debate that comes up constantly in my practice and in the comments here. Walking versus the gym after 50. I looked at the research and the answer is more nuanced than either side admits. See you then.